Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome back to the channel of Standard Medical Notes. I have edited the last video of arrhythmias and have done a lot of research to understand in detail those master flowcharts which I have discussed in the last videos about the SVTs and VTs. So it was not so much clear. So first in this video I will first we will first learn about some different type of ECGs first, then we'll go on to the flowchart so that it becomes easy. Okay, so I think it is a master class on master video on arrhythmia, and after seeing all these 4 videos on arrhythmias, one will not require any other thing to every detail I have covered in this series. Okay, so nobody will require nothing. I think so. So let's start with the name of Allah. So first of all, you remember this mnemonic to see the ECG hearts, HEARTS. What is H? H is heart rate, then rhythm. E is electrical condition, QRS complexes. So you will see the QRS. Whether rate is tachycardia or bradycardia, rhythm is whether the rhythm is regular or irregular. Electrical condition, you will see QRS complex, QT and PR interval. QRS complex, whether there is short or broad, or whether there is some delta wave or some notching at the end of QRS, that is known as Johnson's, which we'll learn in the previous coming slides, and that we will see in QRS complex. QT interval, whether it is prolonged, PR interval, whether it is prolonged, like for example in blocks, or it is shortened, for example in WPW syndrome. Okay, A for axis, whether there is right axis deviation or left axis deviation or extreme axis deviation. R wave in leads, whether the R wave progression is correct, proper, or whether there is poor R wave progression. How is the R wave? Okay, that you will see. T for tension, that means any hypertrophy of atrium or ventricles. STT changes, that means any ischemic changes if we see in the ECGs. So that's how you can see an ECG by this mnemonic. Okay, now we'll move on towards the some ECGs, so that we'll easily break down that flow charts. Okay, so see here, this is an ECG of atrial fibrillation. Okay, rate you can't calculate by standard methods like 300 you calculate 300 by big boxes or 1500 by small squares. Okay, number of small squares. You have to calculate here the rate by 6-second or 10-second method. 6-second or 10-second method. I'm not going into detail of this, just remember rate. Okay, then you calculate heart rate, then rhythm. So see the rhythm, the RR intervals are irregular. Okay, irregular. So that means it is, and there are no P waves here. There are no P waves, and there are RR intervals are irregular. And you can see, now you have seen the rhythm. Now H for heart, E for electrical conduction. No, see the PR interval and QRS complexes are narrow. Main thing is QRS complexes are narrow, and you are not seeing any PR. There is no P wave and any QT prolongation or like that. Then coming to A for axis, any axis deviation. So you are not seeing any axis deviation also here. Okay, left leaves, how you remember left leaves? That means if you see 1 and 3 and the QRX complexes are like this, in 1 like this and in 3 like this, that means they are away from each other, then we will call it as left leaves. That means left axis deviation. And if they are predominantly like this in 1 and 3, they are like this, they are coming towards each other, that is called as right reaches. That means right is right axis deviation, this is called as right. So here you can see there is no axis deviation as such. And then HEA, axis deviation. R you see there is no slurring, there is no delta wave, there is no any special thing in R waves. Okay, there is you can see there is normal R wave progression, from V1 to V6. And then there is no STT changes also. You can see here there is no tall T wave or ST elevation or depression. And then that's all about thing. So irregular rhythm is there. Okay, and the QRS complexes are narrow. That's mean it is atrial fibrillation. There are no P waves. Okay, and you can see this is one thing. You can see some fibrillary waves here in V1. Okay, other sides you can't see, and other sides you are seeing fine fibrillary waves. Means you are not able to appreciate the fibrillary waves. Only in V1 you are able to appreciate. That means this is a fine atrial fibrillation, example of fine atrial fibrillation. And remember the previous classes, fine AF is nothing but it is chronic AF. example of chronic AF. That's about atrial fibrillation. Let's move on to the next ECG. See, this is ECG. See heart rate. You calculate the rate. Okay, calculate the rate. How many boxes are there? You can see the R waves. They are sorry QRS complexes. They are narrow and they are regular also. Narrow regular QRS waves. So it is an example for SVT. Okay, but you can see here there are many P waves in between. Okay, these are P waves, and rate if you calculate in between these two, so they are approximately 4 big square boxes, 300. Okay, by 4 if you calculate by 4, 4 7 are 28 and 4 5 are 75, approximately 75 beats per minute if you calculate by like this. But remember, this is atrial flutter, no, atrial flutter. So ventricles are beating at their own pace. So 75 beats per minute is the ventricular rate which we have calculated now. That is not atrial rate, that is ventricular rate. Okay, now how you will say it is a flutter? See this rhythm strip 2, sawtooth appearance of the P wave, sawtooth appearance of the P wave, sawtooth appearance of the P wave, sawtooth appearance. And not every P wave is followed by QRS complex. There is 3:1 conduction, means after 3 P waves 1 QRS complex is conducted. So ventricular rate is 75 beats per minute, but if you multiply this 75 into 3, how much it will be? 3 5 are 15, 3 7 are 21, 26. So atrial rate is approximately 265 beats per minute. Atrial rate is 265 beats per minute. That's how you are knowing here that it is atrial flutter. Now, one thing you should remember in atrial flutter, the rhythm can be irregular also. When if the AV node is conducting, if there is variable conduction of AV node in atrial flutter, then the rhythm becomes irregular. And it becomes irregular. Okay, irregular rhythm it becomes when there is variable conduction of AV node. So remember one thing here and say, so when there is when there are P waves also and R wave QRS complex also there is there in some tachyarrhythmia. Okay, then two things can be there. Either it can be due to AV dissociation. In case of AV dissociation, atrial rate will be regular. Okay, atrial rate will be regular and ventricular rate will be regular, means different. Atrias will have different rate, but there will be atrias will have different rate and ventricles will have different rate. So that is AV dissociation. Or it can be integral, or it can be some atrial flutter with AV variable conduction. So what happens here? Here we will also see P waves, but the R waves are not following each P wave. Okay, this is not AV dissociation we can say, but it is something which will be confusing. This thing will be confusing. Okay, so remember this, AV dissociation is a characteristic feature of ventricular tachycardia. Okay, and this you can see P waves and QRS. Same picture you can see in atrial flutter with AV variable conduction. That means AV node is conducting some waves and it is not conducting some waves. At that time, the rhythm in atrial flutter becomes irregular, but in ventricular tachycardia it will not be irregular. Here in atrial flutter, when there is variable conduction, it seems like there is AV dissociation, but the rhythm will become irregular. That is a point which we can differentiate between AV dissociation and atrial flutter with AV variable conduction. That's one important thing. It will be helpful in flowchart. Now coming to some other ECG. See, this is an example for again SVT. See, the QRS complex is narrow. Okay, QRS complexes are in the rhythm strip. This is the QRS complexes are narrow and there is tachycardia. Okay, and the rhythm, if you see the rhythm, so rhythm is irregular because the RR interval, if you see, They are not, sometimes they are wide, the interval is long, sometimes it is short. So it is irregular rhythm, irregular rhythm with, so possibilities, what can the possibilities? It can be atrial fibrillation or atrial flutter with variable conduction of AV node, or it can be multifocal atrial tachycardia. These three are the possibilities. Remember, whenever there is irregularly irregular interval with narrow complex tachycardia, there are three possibilities: AF or AFL with variable conduction, multifocal. So in now you see the P waves here. This P wave is different. I will zoom this. See this P wave, 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 see this P wave. That means the morphology of P wave is different. Okay, it is varying morphology. That means this is atrial tachycardia, but it is not monomorphic. It is multifocal atrial tachycardia. Multifocal atrial tachycardia. Okay, remember SVT with irregular rhythm means three possibilities: atrial fibrillation, atrial flutter with variable conduction, and multifocal atrial tachycardia. That's the thing. We will differentiate in AF. There will be no P waves. AF with variable conduction, you will be receiving narrow QRS complexes with irregular rhythm, and you will have 3:1 or 2:1. You will have P waves with this, most commonly 2:1 or 3:1 conduction. And multifocal atrial tachycardia, you will have different morphologies of P waves. Okay. Now coming to AVNRT. Okay, see. This is AVNRT. This is also, even you can see, no. This is an example for ECG of AVNRT, short, narrow, complex tachycardia, and you are not seeing any P waves here, no P waves. And if you see, the RR intervals are regular. RR intervals are regular. Okay, RR intervals are regular. Regular SVT with no P waves. That means it is AVNRT, because in AVNRT you will not see any P waves. Okay. One point you note here is this one. This is the P wave, which comes, this is S and this is R dash pattern. This is S and this is R dash pattern. S and this is R dash pattern. S and this is R dash pattern. Small R dash pattern you can see here after the S wave. So this is also one pattern we have seen. Now mostly there will be no P waves, or some in what do you call, 90% of cases there will be no P waves, or some R dash pattern you can see in V1. That means after the S wave we will have some small bump like this, as you are seeing here. Small bump, arrows are pointed, no, small bump. So that is characteristic feature of AVNRT, R dash pattern. This is one ECG. So we'll move on to the next ECG. See here, this one. So this is an narrow complex tachycardia. Okay, and the QRS complexes are regular. Okay, but if you see the P waves, see there are P waves. Okay, so there are P waves, but these P waves are abnormal. Morphology of the P wave is abnormal, and they are having same morphology they are having. That means from one foci only they are originating. So it is an example for focal atrial tachycardia. Focal atrial tachycardia, only one foci is firing and causing this atrial tachycardia, focal atrial tachycardia. Okay, this is the ECG of focal atrial tachycardia. Now this is some difficult ECGs. Okay, see this is an, if you see, this looks like what, see this, you are seeing here, if you see this QRS complexes, they look like they are prolonged, widened QRS complex, wide QRS complex. So the QRS complex is wide. QRS complex is wide. You see the interval between the QRS complex. See this interval. So interval, RR interval is irregular. That means it is irregular, wide complex tachycardia. What can be the possibilities for this? Irregular, wide complex tachycardia. This is not VT, remember. So this is the trick, not tricky ECG. So the examples for this are, this can be atrial fibrillation, number one, in wide complex tachycardia. Remember, there this is SVT actually, but it seems like it is wide. So atrial fibrillation. Number two is atrial flutter with with variable conduction of AV node, or aberrancy. Atrial flutter with variable conduction, sorry, it can be atrial fibrillation with aberrancy, or it can be atrial flutter with aberrancy, or it can be rarely Torsades de Pointes. Torsades de Pointes, you know the ECG. Okay, so you need to differentiate this atrial flutter with aberrancy, atrial flutter with aberrancy. What is aberrancy? Either there is coexistent left LBBB, RBBB, or accessory pathway. LBBB, RBBB, accessory. So because the interval is irregular, so it can be AF, AFL. This is not Torsades de Pointes. Okay, so you differentiate. How you will differentiate? So you can see here for LBBB, no, remember this one. Williams, one mnemonic I am giving, Williams and Marrow. So this is V1, this is V6, and this LL is LBBB. In V1 you will see W pattern of QRS complex. In V6 you will see M pattern of QRS complex. That means broad QRS complex. In LBBB, this is the mnemonic. Okay, Marrow. So this is V1, this is V6, and this is RBBB. So in V1 you will see M pattern of QRS complex. In V6 you will see W pattern of QRS, widened QRS complex like this. Okay. So that is the mnemonic to remember LBBB and RBBB. Apart from that, in LBBB, see in V1 you are not able to appreciate that LBBB, no, that W pattern. Okay, you are not able to appreciate the W. You are seeing some RS pattern like thing. Okay, you see this V6, U6 you will be able to appreciate M pattern here. See V6 you are having M pattern. So see the left leads, because it is left bundle branch block, you will see the left leads. Along with V6 you see 1 and V6 AVL, you see 1 and AVL. So see in 1 and AVL the QRS complex are M pattern. 1 AVL and V6 will have M pattern, but V1 you are not there. V1 is broad, that's all. Not you will typically see like this, it can be like this also. Monophasic also, monophasic S wave we are seeing here. Okay, which is broad. Okay, so and in 1 AVL and V6 you are seeing M pattern. Okay, biphasic QRS complex. So that means, and the QRS complex is irregular. Okay, that means it is atrial fibrillation with LBBB, and this will respond to adenosine. Okay, this will respond to adenosine. That's so. Remember, when there is irregular wide complex tachycardia, most common it will be AF or AFL with aberrancy. Okay, or with variable conduction of AV node. We'll move on to the next ECG. Again you are seeing here broad complexes. Okay, VT you will think, but it is not VT. Okay, this is an example for AF with accessory pathway. Again it is aberrancy. Okay, aberrancy, AF with aberrancy. So SVT with, that's the main challenge, no, in wide complex tachycardia. You know, difference between SVT with aberrancy and VT. Okay, so this is an example of AF with accessory pathway. Now first you see the RR interval, it is irregular. Okay, and the QRS complexes are wide. Now it can be two things, AF with aberrancy or AFL with aberrancy, but you are not seeing the flutter waves here, or some 2:1 or 3:1 pattern also you are not seeing here. You just see this rhythm strip are 2 and V1. Now you see here, this is the P wave. There is P wave actually. See P wave and R, and then this is R, this is P, and this is S. So M, you are this is looking some like M pattern. Okay, and W pattern here, and but in A1 and AVL you are not able to appreciate M pattern like thing. Okay, but see here in this V6, see this V6 V5. Okay, you are having the delta wave here, delta wave slurred upslope. Okay, and you are able to see here P waves also. So some P waves also you are able to see, but they are, and one more thing is PR interval will be shortened. This is P wave, this is P wave, this is P wave, this is P wave, P wave, P wave, P wave, P wave is there, PR interval shortened, and there is slurring of R complex, that is AF with accessory pathway. So what is happening here is, if you take the heart here, so there are circuits here in atrial fibrillation, there are many circuits, okay. They are predominantly conducting through the accessory pathway. That means it is antidromic conduction. Antidromic conduction. So all the impulses are taking a down path through this accessory pathway, through the bundle of Kent. And remember, this is a very emergency thing which is happening to the patient. Atrial fibrillation along with accessory pathway is an emergency thing. Okay. So you need to treat the patient, and you will not give these patients any of the drugs, like amiodarone also is not recommended for this type of tachycardia. Remember this point. I will research this one. Although amiodarone is effective on the accessory pathway also, but the drug of choice in this type of like AF with accessory is procainamide is the drug of choice. Procainamide, remember this thing, procainamide. AF with accessory pathway, fast conduction, antidromic conduction. This is an emergency, okay. Procainamide if the patient is stable. If it is not stable, you should give DC cardioversion. Moving on to the other ECGs. Oh, one mistake I have made. That is not tachycardia. That is in sinus rhythm. This is sinus rhythm upside, which I discussed. This is sinus rhythm. Now that sinus rhythm has changed to tachyarrhythmia. Tachyarrhythmia. So this is AF with antidromic conduction. That is in sinus rhythm actually. Okay. Sorry for my mistake. That is in sinus rhythm. And this is AF with antidromic. So the treatment of choice is procainamide and not amiodarone, calcium, beta blockers. They will worsen this. Patient will collapse if you give these things. Procainamide is a drug of choice for AF with antidromic conduction. AF in sinus rhythm, you will have delta waves, okay, that gives AQ and short P waves also you can see, and shortened PR interval see, that will give a clue, and irregular interval. So that will give you a clue about that is atrial fibrillation in sinus rhythm. Atrial fibrillation in not you can say in sinus rhythm. It is atrial fibrillation, that's all, with accessory pathway, not in sinus rhythm. This is not sinus rhythm actually, because if you say sinus rhythm, every P wave should follow the QRS complex and the rhythm should be regular. It is not sinus rhythm. It is AF with accessory pathway, that's all. Okay. Okay. But there is no antidromic conduction here. Here there is antidromic conduction. The drug of choice is procainamide. Okay. Now moving forwards, getting short of time. This is a classical example of Torsades de Pointes. See here the QRS complex. If you draw a line here like this in the center, you will see that the QRS complexes are sometimes upwards and sometimes downwards, sometimes upwards, sometimes downwards, sometimes upwards, sometimes downwards. So this is typical of Torsades de Pointes, that is polymorphic tachycardia, twisting around the points. Okay. EC. This is one important diagram to show you for ventricular tachycardia. Okay. So if there is concordance, that means from V1 to V6, all the QRS complexes are either positive or either negative side. Wide complex tachycardia, either positive or negative. So that is a favorable feature for VT. So R to S distance is more than 100 milliseconds. 100 milliseconds actually means more than 2.5 small squares. Remember this one. 100 milliseconds is again more than 2.5 small. What is this R to S distance? R to nadir of S. See, this is R here. Sorry. Starting point of R. See this arrow here. To the lowest point of S. This. Now, if you calculate the distance between these two, this is R. If I say properly, this is R, this one, okay, and this is the nadir of S. So if you calculate the distance, that should be more than 100 milliseconds. Okay, so that is a favorable feature for ventricular tachycardia. The R-S distance should be more than that, nothing but more than 2.5 small squares wide. Now see, these are all favorable features for ventricular tachycardia. Remember this concordance, RS more than 100 milliseconds, nothing but more than 2.5 squares. AV dissociation. AV dissociation, you will have hallmark of AV dissociation is capture beats and fusion beats. These are the hallmark features. You can see here, see this QRS complex is different from all these QRS complexes which are saying. This fusion beat is different from all this. So fusion beats and capture beats are hallmarks of AV dissociation. That is one thing. Okay. Now moving on to the fourth feature, morphology of ventricular tachycardia. So in V1 you can see this is V1 lead. Okay. M pattern you are seeing V1, but in M pattern, remember, you remember the rabbit ears. If this is a rabbit, this is the face of the rabbit face. Okay, this is the right ear of rabbit, this is the left ear of rabbit. Remember, in M pattern, if the left ear is longer than the if the right then the right ear, if the left ear is longer than the right ear, left ear is longer than the left ear, then it is ventricular tachycardia in V1 if you are seeing this pattern. And if the left ear is shorter than the right ear, left ear is shorter than the right ear, right rabbit ear, then it is right bundle branch block, it is not ventricular tachycardia. So these are the hallmark features of ventricular tachycardia. 4 features: concordance, R2S more than 100, AV dissociation, capture bit, fusion bit, morphology in V1. 4 things you remember about ventricular tachycardia. Okay, see here, note same thing. You will have RSR dash pattern. So this is some, just remember left ear and right ear. Left ear will be more than right ear, that is VT. Right ear is taller than left ear, that is RBBB. Right is taller, so R for R, RBBB. Right is taller, R for RBBB. Right is shorter, that is not RBBB. Okay, so RSR dash pattern. Okay, this is big R, this is S, this is short R. And RS capital R dash pattern. This is small r, this is small s, this is capital R. This you should know. Okay, 4 features, very important features in this box you should remember. Moving towards the ECGs of VTs now. Okay, now if you see here, the QRS complexes are irregular, they are regular, and if you see, these are broad also. Okay, so they are wide and broad. Now you should rule out whether it is bundle branch block is there or not. Okay, typical bundle branch block or atypical bundle branch block, 2 things are there. So if you see the lead 2 you are seeing T wave. This is T wave. So this is QRS complex and T wave, QRS complex and T wave, TRS. So and wide complex it is. Okay, and if you see this, see here, very important, huh? This is not VT actually, remember, this is not VT, this is wide QRS complex with typical bundle branch block. This is SVT. 1 AVL V6, you are seeing M pattern, and remember Williams. So Williams means in V1 you will have some broad bizarre pattern of W like thing, or monophasic S wave you can say. But if you see 1 AVL and V6, they are typical of LBB, they are typical of LBBB. Okay, so this is not ventricular tachycardia, this is actually wide complex tachycardia, regular wide complex tachycardia with LBBB. So this is SVT with aberrance actually. So it will respond to adenosine. If you give adenosine, you will know what type of tachycardia it is. Okay, and if you note here, okay, that's all. This is wide complex, this is SVT with typical bundle branch block. There is no concordance like thing, there is no R to nadir pattern like thing, and there are no fusion beats and capture beats. V1, if you see V1, okay, but V1 is helpful only in RBB pattern, no? RBBB pattern you helpful in your typical RBB pattern, but you are not seeing any RBB pattern like thing here. Okay, in V1. So LBB pattern is there. So this is wide complex regular tachycardia with aberrancy, left ventricular branch block. Now we will move towards same thing here, typical LBB. So regular broad complex tachycardia with typical LBBB. M pattern you see in lead 1, AVL and V6. So you should see always, if there is aberrance here, if you are considering, you should see V1, V6, 1, AVL. These go with their way, and V1 you should see rabbit ears. V1 you should analyze like rabbit ears, okay, for RBBB, SVT the RBBB. Now, so other ECG. So this is an example for regular broad complex tachycardia with RBBB. See here. Now these are regular rhythm. QRS complexes are wide. QRS complexes are wide. But if you see this, see the V1. See the V1 here. I will zoom this. You will clearly see. See the V1. See V1. If this is the left ear and this is the right ear, then right ear is taller. Right ear is taller than the left ear. So that means it is RBBB. RBBB. Along with that, sorry. Note RSR dash in V2 or V1. So RBB you need to see V1 or V2. More appreciable you can see here, see V2. Right ear is taller than left ear of rabbit. So that is right bundle branch block. And you can also see W pattern in 1 and AVL. See the one, lead one. Yes, you can see here, see W pattern. Okay. Here also one and V6, no? This is W pattern. W means this is monophasic S wave which is large. So that means so this is characteristic feature of so you will see W pattern in 1 and AVL, and right ear will be longer rabbit pattern in V1 and V2. That's about wide complex regular tachycardia with typical bundle branch block. Now moving towards the other ECGs. See, this is an example of positive concordance. From V1 to V6, all are broad complex regular tachycardia with positive concordance. Okay, that is the example for this ECG. Going on to the other ECGs. See, this is example for negative. All the complexes are negative and they are broad, and you are not seeing any bundle branch. See V1 and V6. You are not seeing any rabbit-like pattern in V1 and V2. Okay, rabbit ear pattern. Or if you are seeing, see, if you consider this as right ear and left ear, then the right ear is taller, no? Right ear is taller. See here. This is right if you consider, this left if you consider. Right ear is taller. Right is taller than the left in V1 if you see. So it is VT, not bundle branch block. Okay, it is VT. This is negative concordance. Okay, negative concordance. And if you calculate the nadir also, starting from the starting point of R wave to the, this is starting point of R wave to the nadir. See here, this is more than 100 milliseconds, more than 2.5 small squares. So it is easily, it is VT. You remember this nadir. This is an example to two signs. One is Josephson signs, left side here, and one is Brugada's sign. This is right. So this Josephson's signs is what? Notching near the nadir of S wave. Nadir is nothing but the deepest point of the S wave. Okay. So this notching, this one, this notching near the nadir of S wave, if you see, that is known as Josephson sign. Now, if we calculate the R to S, deepest S, and if you are getting more than 100 milliseconds, nothing but more than 2.5 squares, small squares, 2.5 small squares, then it is known as Brugada's sign. This is Brugada's sign. And this is Josephson sign. This is Brugada's sign. Remember, Josephson sign, Brugada's sign. Typical for ventricular tachycardia. Moving on to the next ECG. I think I need to take one more video. 5 videos it will be there, but I will do that thing. So this is an example for VT. Till now we have seen all the things. SVT with aberrancy, AF and AFL with aberrancy, how to differentiate those things. So by seeing the ECGs first, if we see, then it will be easier to follow that flow chart. Okay. So here you can see complexes are regular, they are broad. Okay. and from V1 to V6, if you see, there is concordance, positive, all are positive. And you see 2 years, this is 1 year if you consider, and this is 2 year. You see it as, this is not like ear like thing, okay, you can't see this as ear like thing, sorry. You can see the Josephson sign, see this notching, see this notching, Josephson sign. Now if you calculate the nadir here, this one to this point, this is more than 2.5 small squares. So this is ventricular tachycardia, all the features are met, okay. There is no RBBB like pattern, there is no LBBB like pattern, okay. This is not RBB pattern, okay, this is not LBBB, okay. You are seeing Josephson sign and all the currents. So the features here, they are there. See, there are very broad QRS complexes from V5 to V6, very broad complexes. Brugada sign you are able to see, Josephson you are able to see, possibly some superimposed POS in AVF also you can see. So remember these things, this one. That's typical of monomorphic VT. This is another example, okay, of monomorphic VT. Now if you see here, here see, this is right ear is more than left ear, and all the QR complexes are positive, concordance is also there. There is no Josephson sign, but if you calculate the Brugada sign, it is positive, okay. And this is regular, so this is VT, very easy. Taller left rabbit ear, this is very specific for ventricular tachycardia, okay. Taller left ear, okay. Now this is also an example for monomorphic VT. Now see here, this is very tricky thing. You are seeing here left ear, right ear more, but that suggests RBBB and complexes are broad. But along with V1, you should also see 1 AVL and V6. This is V6, okay. In V6, sorry, the problem of this tall monophasic R wave in V1 with an RS complex in V6. See the RS complex in V6. This is R and this is tall, very deep S. This is short R, this is very deep S. Short R, very deep S. Short R and deep S. So short R and deep S. Okay, short R and deep S. Tall monophasic R wave in V1. This is in V6 we have seen, no? V6. And if we see V1, you can see tall monophasic R wave. You are not seeing any bifid like pattern. So this is feature of, this is not what do you call, left right ear is strong, so it is right bundle. It is not RBBB SVT with RBBB. This is ventricular tachycardia VT. So why it is VT? You should also see V6 also. In V6, if there is RS complex, then that is, and tall V1, if there is tall monophasic R wave, then it is, you remember this pattern also, this pattern, tall monophasic R wave and RS complex in V6. This is also typical for ventricular tachycardia. Moving towards another ECG. So to know RBB and this is RBB. See, the right ear is stronger, but these are short, narrow QRS complexes. So this is marrow, right bundle branch block. M pattern in V1, W pattern in 1, AVL and V6. Okay, W pattern, that means wide QRS complex, okay, not typically W you can see. LBB you see left bundle branch block. So in RBB you also see left axis deviation, right axis also. See here, there is left axis deviation, okay. And see, in 1 AVL V6 you are seeing M pattern. So this is LBBB, okay. V1 you are not seeing that thing, you are seeing monophasic S wave, okay. So that thing, monophasic tall R wave with small r, big S in V6, broad complex tachycardia is nothing but VT, okay. That you should remember. That is atypical LBBB, you can say, atypical. That's all about the ECGs which we have learned. So I think I will take another class. Now we have learned the ECGs, different ECGs, okay. Now I think it will be easier to understand those flowcharts, okay. So we will meet in the next video. One more video will make, so 5 videos will be there. So after that this topic will be closed. Thank you for your listening. If anyone doesn't listen also, I don't care, because it is benefiting me. Okay, I'm learning this.